guys? You weren't here yesterday. Were there any other issues?
No, meaning that I can't.
Hold a minute, please. Or any issues with the person here yesterday? You fully understand what the concept mapping was about? Okay, so we're gonna move straight on to now to the care planning. Okay? Yes, ma'am.
No, I couldn't open it, that's all. You did send it to me, but I can't open it, I don't know why.
We'll just have to listen to what it is and see how we can rectify that for you. All right? Hello? Now, one of the things I promised yesterday is that today we'll be looking at the care planning and the care planning format and how that concept mapping will play into your care planning. So yesterday, after doing the concept mapping, you noticed that you had to focus on what the patient is complaining of. And moving from what the patient complained of, you next went to your nursing diagnoses, and these nursing diagnoses were based on your subjective and objective data. And this was related to the medical diagnoses, including what? Including what along the medical diagnoses? I bet I did not send it out. Let's move on. Let's go down to the bottom with the nursing interventions now. You do your nursing interventions based on what you pick up for the nursing. Let's go to the care planning. After the care planning, guys, don't waste my time when I send stuff out. I have no time to waste with this nonsense now, please. If I send something out, I expect you to read it home. I explained it in detail yesterday and took more than 3/4 of the session on the mapping. So please, if I don't hear from you, then I understand that you understood. And you don't have to ask any questions, so we just move on. Okay? Now, with your care planning session, you did the ADPI. And then we develop a care plan whereby now you're not only doing the ADPI, but you must be able to explain why you choose nursing diagnoses, why you choose the interventions that you picked. Therefore, you must know the subject inside out. You cannot just put something up there, including if you take and plagiarize, because doing these care plans is a learning experience. And this learning experience is based on you understanding what your role is as a registered nurse and development of care plans, because that's what you will be doing. You will get software and the jobs where you'll be putting up the care plans, but you now have to what? Make it specific to the patients. And if you don't understand about this process, then you will have an issue. But during the time as a student, doing the care plans that way with the concept mapping is for you to learn that you must know the rationale for everything you do. If you put something in a care plan, you must know why it's put there. You must understand the medical rationale. What are the lab tests? What are the other clinical ramifications that are involved? I will not, I'm going to say it again, I will not be giving you guys what I did yesterday and send information to you if persons don't read, so we can have a meaningful discussion. Because I said that's what we're going to do today.
No, you said.
I said we will do a meaningful discussion today on blood work, right?
You said us to read about
Blood work is leukemia, isn't it? So I said that we will be having meaningful discussion on that today. With reference to sending you all that information, I am not going back, as I told you persons before. If you miss a class and we don't have the groups, you better get on the phone and call another student. Because, I told you guys I'm not into sending these information out. Because persons don't read it. And it just don't make sense. Because what I've been doing for all the time I've been in this classroom is going back and going back. So instead of taking 2 steps forward, we're taking 3 steps backward. Because I keep going back, and we have a lot to complete before May. 20% of your time of learning is in the classroom. In fact, I put it to 10% of your learning is in the classroom. The 90% is at home. So if you do not utilize that time, then you will be wasting your own time. Before, I used to send you your schedules and put everything, and then when I ask persons what's in the schedules, they don't know. I told you yesterday I did not want to send out that clinical mapping, the concept mapping, for a reason. So when we have this now, what's going on, then I have a serious problem with it. Westwood, can I help you? Speaking. I'm pretty good, thank you. Yes. I will consider work as a director, but I am not going to work in corporation. With the corporation, I'm going to be meaning it's I will consider. That's why I think there's open
How we want to use it now, the way he's teaching us, the community is too low. The middle of the program where don't take should be done at the beginning. You understand? Because this is the basic. One fait des étapes jouer là, by the time the capacity qui va la faire yesterday long time.
All right, on the care plan, you had specific areas that we had to look at. And you remember the ADPI, right? Which you did what? Assessment, diagnosis, planning, including the goal. What else? Intervention, and then evaluation. But then I added 3 more areas onto that. And those 3 areas were pathophysiology. And how does pathophysiology relate to the care plans?
Rationale.
How does pathophysiology?
The disease process.
It tells you what?
The disease process.
It tells you about the medical disease and the process. So whatever is a medical disease, you're going to be writing, because this medical disease is what caused the patient to complain and you for develop what?
Care plan.
The nursing diagnosis. Remember in your mapping, you had the central was what? What the patient complained of. Then you have up here is your nursing diagnosis with based on what? Subjective, objective. And this leads on to what? Your medical diagnosis, your what? Patient who are at risk, the vulnerable population, lab tests, all of those things that only the doctor is into, not you. And then you lead on to the next, which will be the interventions. And into interventions, the interventions must be specific to what you as a nurse will be doing. Is that understood, guys? And everything must be related to what the patient is complaining of. Whatever the patient is complaining of, that's where your nursing diagnosis is coming from. Your nursing diagnosis is not going to be myocardial infarction. Nursing diagnosis is not going to be angina. Because I review some of those care plans that was given to me. And I see that person made mistakes. So we are correcting it now for you to learn and understand how to approach it. Because everything that you will be doing, and when I mean everything, not just writing, but an informal process which goes on in your head. From the time a patient comes on the floor, you must know what you are about. If the patient comes on the floor, I've come up from, let's say, from the ER, they will send information up to the unit, med-surg unit, patient coming up with whatever. As soon as you get it and you being the nurse on the floor, you have to start doing an informal process in your head. You don't just prepare a bed, tell the patient to go get a bed, and what have you. It takes more than that. So with the informal process, you need to know what you are about. So based on what I gave you yesterday in that mapping, clinical mapping, what would be the assessment based on that map I gave you yesterday? What would be the assessment that you're doing? What would be the subjective data? What's that? I give you the information yesterday when I sent you that stuff there. So is that exactly that you're using for the care plan right now as we're talking about it? What is it that the patient complained of?
Shortness of breath. Tiredness.
Blurred vision.
All right, the patient complained of those things, right?
Yes,
But then in the subjective data, on the left, you had something there. On that subjective data, remember when we did the nursing diagnosis, we said the person had ineffective what? Health management. So based on ineffective health management, meaning the person needs to be what? You need to teach that person. Right? So if you're teaching that patient, so the subjective data, we're just doing the care plan now. That's what you're doing here now. The care plan based on what we did yesterday on the clinical mapping. So you just tell me what we'll be going through.
care plan. Diet.
What was the care plan? What was the nursing diagnosis? What was the nursing diagnosis? So the patient have ineffective management. What did the patient say for you to come up with ineffective management? She did not know how to take care of herself. And one of the things she said is what? Talk to me. Tell me what I need to do, right? So that's what's her problem. She just didn't know what to do. So that's subjective. Look at the blue upper section. The bubble on the far left upper corner. Yeah, read it, please.
I was the one that the hard reading I got from my friend senior. I have never used the meter before. Please tell me what to do.
Okay, full stop. The patient subjective data was, I was alarmed. And she ended by saying, please tell me what to do. So what is she doing? She is asking for help in how to manage her care. That's why you come up with ineffective health management. If you look at Hernandez, well, let's say you now look at your Hernandez. If you put down nursing diagnosis, patient unable to take care of themselves, I would accept that. Why? Because you're using a simple language under the nursing diagnosis. But you have to know why you put it. Because a patient is telling you there. Alright? Although the central concept when the patient went to the hospital, the patient is what? Having polyuria, polydipsia, all those nice things. But what did the patient actually tell you? That she was alarmed, or she took her friend's what? To come with her. She did it, and it was 275, right? And she just said, I don't know what to do. So she needed help. So once you use this, I don't know what to do, it means now the patient need what? Patient teaching due to ineffective health management. She can't take care of herself. Is understood? All right.
Yep.
And what will be your objective data?
The vitals. Check the blood sugar.
Blood glucose level, exactly. What else?
Blood pressure,
The what?
blood pressure.
Objective data. You cannot explain to the patient how to do it yet. You're still in the what? Assessment. Look at the blue bubble. Look at the blue bubble where Mr. Etienne was reading from just now. Patient was eating a high what?
Fat, high carb diet.
Okay. The objective data will be, and I'll read from the same thing relating to that. Data is effective choices in daily living for one meeting health goals as evident by blood glucose level, which is high. 2, patient had a high what? HbA1c, right? And 3, what Mr. Etienne was saying, The patient was eating high
Fats, high carb
carb,
diet.
fat diet. That's your objective. That's what you can see. That's what you know. You see the lab test and you see the diet. So that is your objective. That is not what the patient telling you. What the patient told you is that they took the blood sugar, but they don't know the hell is going on, and they want you to help.
They don't know the number.
Are you guys with it?
What situation?
Maybe 6 o'clock. Go brush your teeth. Go brush. Did you brush your teeth already? Is your patient already? Where's your brother? Good kids. Turn on the TV. Did you pray? Pray. No, Sweden look and money. Okay, that's a different one. Let's go. Yes. Turn off the light. Good night, my love. Good night, Papa.
What do you mean? You can't find your email? That's your email, no? You have Gmail?
Don't you go to bed? I'm not feeling it. Go to bed right now.
You don't go there.
Why are you still on the phone? Why am I seeing more light? You playing game? Oh, right now.
You was here yesterday?
Yeah?
You was here yesterday?
No.
Renex, you was here yesterday? You was here yesterday? Did he leave the class in the middle of the class yesterday? He did the same thing yesterday, right?
All right, we're just at the objective assessment and some of the things that you look for with your objective assessment. And so now we go to the nursing diagnosis, which was what? On your the bubble, what do you see there as your nursing diagnosis?
So it says type. No, okay. It says educate. No.
Look at the nursing diagnosis.
Okay, risks for impaired skin integrity.
Look at number one. Bubble number one,
Self-health management.
ineffective. She's having problems with taking care of herself, right? So that's called ineffective self-health
Management.
Not able to take care of herself. So, and this is related to the definition on, are you guys okay? All right, this is related to the patient having what we call knowledge deficit. Not understanding the disease, not knowing how to utilize equipment. So that's where you come up with an ineffective self-help management that's related to knowledge deficit. All right, now the self-help deficit, the knowledge deficit, sorry. Now this therapeutic regimen, it says evidenced by what she reported, and what she reported was that she's failed to know how to check the glucometer. She just didn't know what to do. So under that nursing diagnosis, you will put that information in. The nursing diagnosis will be
Self-care.
effective
Self-care.
care management, right? And this is related to knowledge deficit as evidenced by what? Can't read the glucometers, not fully understanding diet. She's eating whatever she feels like eating. So you need to put those down under the nursing diagnosis. And then you go on to the next, which is what? Pathophysiology. So what is a pathophysiology? You're going to write a nice little summary there. So what would you write from the bubble? And which bubble are you choosing? You'll be choosing the medical diagnosis to get that pathophysiology. Remember, pathophysiology is what the doctor is doing. It's a disease process. So whatever the disease process you're going to be putting down is based on what the doctor came up with the diagnosis of what?
Type 2 diabetes.
Type 2 diabetes. And what were the tests that he did?
Hemoglobin count.
A1C, right? What else?
Fasting blood. In the fasting.
Look at the health bubble on, your medical bubble on your concept map.
Fasting blood sugar and A1C.
Pathophysiology, and I will read diabetes is a metabolic disorder characterized by relative deficiency of insulin production and a decreased insulin action and increased insulin resistance. Normally insulin bind to special receptors on cell surfaces and initiate a series of reactions involved in glucose metabolism. In type 2 diabetes, these intracellular reactions are diminished, making insulin less effective at stimulating glucose. And also, it affects the regulation of glucose released by the liver. So what did you understand this, what I just read about the pathophysiology? What do you guys understand by what I just wrote?
The glucose that's released cannot be utilized. For that reason,
And that's good to put in, because what you were going to be writing, or what you are going to be writing, is your understanding of what the disease is about, what diabetes is about. You're writing a summary. You're not just going to put down A1C by this, no. You're going to be writing a summary of what you understood. Let me just read it back again to you guys, so give you an idea. It says that diabetes, a metabolic disorder characterized by the relative deficiency of insulin production and a decreased insulin action and increased insulin resistance. Normally insulin bind to special receptors on cell surfaces and initiate a series of reactions involving glucose metabolism, and went on and on and on. So basically what it's saying is that, you know, when I asked you to look up a word, and then you find, or you found what that word means? You see how you have that definition? And taking that definition, put it into your own words, and write it. That's how you do the pathophysiology. Not just say X, like in this case, A1C. Dietary this, no. What is pathophysiology? What is a disease process? You guys understand? So if I had a situation, the person was not breathing, having effective breathing, impaired breathing pattern, and they had a condition of COPD, how would you write it? How would you write it? Basically, just when you look at what is COPD when you Google it, you take it, that information, and you don't plagiarize. You put it into your understanding of what it is, and put it in the pathophysiology. That's all. Say again? Don't paraphrase.
Summarizing.
That doesn't mean you be summarizing.
So in that situation, I would say ineffective tissue perfusion.
What's that?
In that situation, I would say maybe I would say ineffective tissue perfusion.
That's a nursing diagnosis. We're not looking for nursing diagnosis.
Okay.
What you're looking for is a pathophysiology. What is type 2 diabetes, which is non-insulin dependent diabetes, right? What it is. That's what it's asking. What it is. Because they want to know, we put the diagnosis, right? And effective management. So how the hell are you going to teach somebody if you don't know what is the disease about? Are you guys with me? So that's what pathophysiology is about. When you make a nursing diagnosis, you don't just write a nursing diagnosis. You must understand the pathophysiology that supports what you give as a nursing diagnosis. Are we on the same page? It's like if you're talking to her, you're the nurse, right? And you explain to her what is diabetes. But now you're going to put it into writing. But that's all it is. The pathophysiology is a disease process, but you now be teaching somebody and you'll be putting it into the words to show that you fully understood what it is about. Alright guys? Now, seeing that we went to nursing diagnosis, we got it. We went to the pathophysiology to understand why we come up with the nursing diagnosis. Now you have to have a goal, right? And your goals are usually broken down into what?
Intervention.
No. Your goals.
Intervention.
What would be your goals? What is your goal for your nursing diagnosis? What is your goal? What you hope to achieve? That's what the goal is. What you hope to achieve.
And then to be able to
Right, but based on what you have there, what
Your
would be
plan.
the goals based on what you have there?
for the patient to learn how to use
How we going to apply? How we gonna
We're gonna manage those.
apply the medication
The
and
medication, I will take care of the patient.
that? How you monitor the patient?
All right. Normally when you do goals, you have a short-term goal and a long-term goal. Right? So what would be your short-term goal for this patient?
To monitor the patient.
Same thing that's on that clinical mapping, the concept map. Your short-term goal is that within 24 hours, you want this person to what? Understand how to do the glucometer. You don't want her to understand in a month. You want her to understand today. So she can do her finger stick. So that would be a short-term goal. What you think will be your long-term goal? It's right to know level.
movement intact.
And what?
The patient's skin movement intact.
You know, you're impaired. That's not to the what you say?
Already accomplished the short-term goal, you know to do it.
I can't hear. Guys, quiet please. Say it loudly, please. And one more time, what will happen? The report what? What's the long term? In 1 month time, the client will do what? Look at what you have. The patient in 1 month will be saying that she go there at least for 30 minutes and do what? That's a short long-term goal. Because the goal is for her to understand that what? She taking the glucometer to learn how to take to do the finger stick. And the long term is what? She have to what?
Exercise.
And she got to do it 5 times a week for 30 minutes. That's a long-term goal. And it's all related to your nursing lectures. Because you're teaching her, telling her.
Also the change of diet, right? Change of diet.
Change
as
the
well.
diet. She will not be utilizing that what?
Low
The
carb.
high carbohydrate.
Low carb diet.
The reason why I'm going through this with you guys is that next week I need to see till Monday. I need this care plan that I'm giving you on Monday. Okay? So that was our goal. Then the next was what? Outcomes and planning. And for your outcome, what you hope will be the outcome? The outcome is that patient will able to do the finger stick, glucometer monitoring. That's the outcome you expect, right?
Mm-hmm.
Your goal was to shorten, to teach her how to use the what? The glucometer that you learned in the day. So what's the expected outcome? That she will now be able to. There you go.
Effectively.
Alright? And what's the next one you think the patient will be telling you? The outcome? She that have initiated an exercise program. She's going and run what? Or exercise 5 times a week. She's got a program. The outcome, patient will have a program. Because doing all this teaching, right? So this is where the outcome is. And the next column is what?
Evaluation.
So let's go to nursing interventions. So what are your interventions now?
Educate the client on use of blood sugar meter, including time and frequency to test.
There you go. That's a nursing intervention. That's what you're actually performing now. You're actually what? Doing the intervention. In your goal, you said you're going to teach her. The outcome, you said what you want. Now you're going to sit down to do the actual teaching. Because this is not the patient teaching. You guys with me? Because these are blank faces. It's something you guys don't understand, say it now. Alright. So for the nursing intervention, nursing or interventions mean what you actually will be doing. And you actually be sitting down with the patient and talking to the patient. Telling them, look, this is how you do the glucometer, whatever. How you write the report, how you write, the results, or you record it. Those are things that you will be talking to the patient about. You'll be doing patient teaching. And for those who are LPNs in here, you might have seen your RNs doing patient teaching, and then they have to what? Document that the patient show what?
Understanding.
Demonstration. Alright? Next was what?
Rationale.
Rationale. And what do you think the rationale is about?
why you are doing the intervention.
Rationale is the reason why you use the rationale. So the rationale, and I'm going to read to you. Using and learning how to respond to results enable people with diabetes to individualize their treatment to obtain optimal blood glucose control. This allows for detection and plays a crucial role in normalizing blood glucose level, which in turn will blah, 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 blah. Basically, what you want to say at that point is that by this patient knowing how to do their blood glucose testing, the finger stick, they will now fully understand what the diet has to do with it. They will fully understand when they should eat and what they should eat, and how high blood sugar level or low blood sugar levels can affect them, and what should be their what? Response. That's why you do the teaching, right?
Yeah.
That's the rationale for the teaching. Why are you teaching? So this person can understand how to what? Take care of themselves by using their glucometers. Finally, when you get to evaluation, what will be your evaluation? What you hope to achieve in evaluation? But remember, evaluation is basically what
The goal.
the patient,
The goal has been met.
if the short-term goal was met and the long-term goal was met, because it's only two you focus on, right? The short-term, the glucometer, and the long-term, the exercising. So when you guys do that, do you understand that? Actually, on that that I give to you, you had two nursing diagnoses. Nursing diagnosis 1 and nursing diagnosis 2. And the second will deal with impaired skin integrity. Because the patient is complaining of what? Problems with the feet. As we know, diabetes can cause persons to lose their toes, get ulcers and all kind of stuff. Right? So that will be the person at risk. What you have in diagnosis 1 is an actual situation. Diagnosis 2 is a potential, because this person is having and complaining of the sensations in the feet. I remember on that clinical, on the mapping, the performance by the nurse to check the sensation or the sensory perception in the feet, we said that the nurse will do what? The nurse will get a cotton and the patient to close their eyes and relax in there. And they feel it. And if they don't feel it, you know they have a problem with their
Blood circulation.
and then after using this cotton and they didn't feel, you want to know how much is it. So you go with something a little what? Harder. So now, don't use your pen and hold it by the foot. Use a pen. And you touch it, touch it. And if you say, still not feeling, then you know the problem. Okay? Now, this is your approach to the care planning process. This is your approach to everything that you do in nursing. Everything you do in nursing school, this is it. This is a learning process. You must understand what is pathophysiology. You must understand why you do things. You don't just say, I will do this, and not understand the rationale, why you're doing it. So moving forward, you will be doing care plans a lot. On each of those systems that we have coming up, you will do care plans. And you will do care plans this way. Not an ADPI, regular ADPI. You will be utilizing the care plan that asks for what? Pathophysiology, your understanding of the disease process that you're trying to tell the patient about. You're going to talk about outcomes, and you're going to talk about rationale. Why you decide to do what you're doing. Is that understood, guys? Hello? So, what I want from all team members in the classroom today, I need for you to do the clinical mapping. Sorry. I need you to do the care plan for next week, Monday, on what you were previously asked. I know I see some persons have given to me some beautiful care plans, but with this care plan now, these are the same topic, so you already should have it on your laptops. You're now going to add in the nursing interventions, the two that's specific to the nursing diagnosis. One, and the second nursing diagnosis also related to whatever you come up with. I'll tell you what comes. I'm going to throw aside, say, do the NIDDM, do the care plan, the one that you did before, the one that you guys did. Some of you give me the advice, some of you guys give me the pathophysiology. Although there was a lot of errors in erroneous material on it. Now, after explaining what it is, I want you to go back in and based on my explanation, try to do your care plan that way. Because moving forward, pretty much you do care plans at least twice a month. At least minimum twice a month. And not only that, for the one that you did, care plan, I also want to see a concept mapping. How you feel about what you do.
So you want a concept map for one day?
I need the concept map and the care plan on one day. So understood that? Whatever's your care plan that you did before, whatever was the nursing diagnoses, you put it on your what? The concept map. Because the concept map is what develops your care plans. So put it on your concept map. Put the nursing, just look at the concept map, the one that I sent to you. And based on what we talk about today, develop a concept map. And this concept map must be in line with what you're doing on your care plan. Because what's in the concept map is guiding you towards the care planning process. Is understood? Yes, ma'am.
So we can do it.
I have it, and I can send it. Most for you, you have it in your, right.
Plan go
Why-
the same time.
Listen to me, guys, listen to me.
Same time.
I have all of your ones that you give me, the archive and so on, with some corrections and what have you. But I will be giving it, I'm not going to give it to you now. And there's a reason why I'm not going to give it to you now. But you guys have it in your, you should be having it in your laptops. That's why I did all the work with your laptops and all this sort of thing. You need to be more focused on it. And now I want you to take it. And based on what I said, I want to see what you will do. I don't want you just to look. I want you to listen to when people are talking, ask questions to understand, and then let's see the outcome. All right?
Professor.
Normally, when you are in, you normally do something called Prep U, right? And you know what Prep U is? Tell them what Prep U is.
But you basically, if someone went up maybe your homework or you do an exam, and then if you like put the exam of correctors for you also, this is, school use it for exam and homework to do that.
And another quiz. Quiz, all the time. And you bring it on your quiz because you want to know what, basically it tells you what you don't understand. It guides you. So it'll be a lot of quiz, prep you. And it's for you to understand.
This is
And the teacher will be looking at what you do
three more times.
and see where you're at.
The same time.
But add more
I'm not trying to tell you guys to buy prep.
That's the
I'm
homework.
trying to tell you
That's
to
the
do X,
homework.
Y, Z.
Most of the time, eight
I'm
college.
trying to tell you to utilize different things.
Understand.
I give you sites. The school will give it to you, code, what have you, but some schools won't tell you to, you gotta buy it. Right? Colleges will tell you, you gotta buy it, you gotta pay for everything.
Question.
But I don't want you to buy prep. What I want you guys to do is to do those, like, those are those entrance questions that you have free on those sites. I want you to keep doing it and doing it and doing it.
So this homework that you're talking about, is it? Can we have like 2 papers, or are we putting everything into one?
There gotta be 2 papers.
Okay, just
One,
making
the
sure.
first one, the concept map is your understanding on how to plan for a care plan. So now, after you've completed the concept map, what's on your concept map should now go into your care plans.
All right. Just making sure. Thanks.
It's 2 different things. Concept map is just like how you got the concept map I sent to you. You put whatever you know about the care plans that you have done before, put it on that, and see what you've been doing wrong. And then when you put it together, now you go to the care plan and put it into your care plan. That's what it is. Is that easy?
Yes.
Everybody clear on this thing? Because with this, you will understand, by the end of it, you will understand whatever the problem you're looking at.
Okay.
Whatever you want to say like this. All right?
Okay.
Now, guys, give me approximately 10 minutes. I'll be right back. I do need to put my, it's too hot. So I'm putting on my coat so I can become cold.
Hi, baby.
How are you? Okay. This is like a concept map right here.
Oh, this one?
Yeah.
Oh, you do another page? Want to pay for it?
It's like a concept map right here. Write the name of the disease right here. Write the name of the disease right here. I came up with this. It's not mine, but I got it online.
That's when you do it separate. What you think?
You do separate, 2 papers.
This one is separate. You do this one, and then this one.
Separated.
Oh, it's a lot, Joe.
This one and then this one too. That's the care plan, concept map. You want the concept map first, then care plan.
What you think about
Natalie, que foi capaz de Mesmo a pessoa pode gravar uma pessoa pode gravar All my time last night,
Qui nous place ce matin ici avec les gratuits? The other ORN 2022. Not work in the hospital. Don't go work in the hospital. Try nursing home first.
I'm just gonna forward it and get it
Rika, you go home work twice, okay?
Rika, where's Anita Paris? Where's Anita Paris? Like,
Now he's
Même pas que je me maquille, pas que je me maquille. Pas que je me maquille ça, mais. Comment on va la Oh, I'll be
IKEA. Nursing diagnosis is something with assessment.
Nursing diagnosis is something that the nurse is going to address.
Is it something with assessment? I know nursing diagnosis is objective and subjective. How the person tell you what information the patient give you. Nursing diagnosis is what information the patient give to you.
Yeah.
What you tell you, everything you tell you.
It's related.
Yeah,
It's related.
yeah.
I want perfection.
Dia acabei um lado dele. I don't know why you're not doing it. You can give it to her, not their homework. It's like the same thing. This thing is
Please use baby. Put on make Kuna le nouvelle wale na albi non pa ou so wale na albi en fait non pa ou fait comme ça il pas bon pas plutôt mais dans il pas bon pas plutôt mais dans so you have to open that this who are you going to? You going to somebody else wale na open et vous faites open là cliquez il va
Research. That's what he said. When you're doing something, research.
Yes. An nouvel kon sa pou wè. La nouvel kon sa pou mwen informasyon. La an fevriye. Bal moun bal sa fè sa li pa ki komi. Pa se wè et kon gade.
What's the topic for the homework?
Se li seulement li
What's the topic for the homework?
Whatever we do gonna be good.
He didn't tell us exactly what it was. On what topic? On what topic? On what topic?
Kung wala ka ba? Yung mo sa liyak ni, yung mo sa banyo na
Gastric ulcer?
Pa beze chanjan, yon beze mette sa nou fè joun baby la. It's not gonna work. You have to give you access to do it. You cannot give you the access to read it, baby. Because
That's why you can choose any sickness. You can choose any sickness.
The one you did before for the homework. The one you did for the homework.
You can choose any sickness. Which sickness you can choose?
The one you did for homework.
You give it to us a special sickness.
No? The same one we did for the homework. That's what he's talking about. I don't know. He's all over the place.
même qui est Excel, pas de Excel.
Word aneurysm is based off the smooth muscle of the tuning.
No, okay. Let's do this. Let's do the RV stuff. We need the clips. Then let's do the clips. Let's do the...
With chronic leukemia, leuc refers to white blood cells, and emia refers to the blood. So in chronic leukemia, there are lots of partially developed white blood cells in the blood over a long period of time. These partially developed white blood cells interfere with the development and function of healthy white blood cells, platelets, and red blood cells. Now, every blood cell starts its life in the bone marrow as a hematopoietic stem cell. Hematopoietic stem cells are pluripotent, meaning that they can give rise to both myeloid or lymphoid blood cells. If a hematopoietic stem cell develops into a myeloid cell, leukemia is a cancer of bone marrow lymphoid cells, which is normally Leukemia is a cancer of bone marrow progenitor cells that spreads into the bloodstream, and it typically causes the white blood cell count to exceed 11 times 10 to the 9th cells per liter. This is in contrast to lymphoma, which is a malignancy of white blood cells that arises from the lymph nodes. leukemia can be classified based on cellular lineage. So it's myeloid for granulocytes, which include basophils, eosinophils, neutrophils, and mast cells, and lymphoid for lymphocytes, which include T cells, B cells, and natural killer cells, basophils, eosinophils, neutrophils, and mast cells. Leukemia can be classified based on cellular lineage. This is in contrast to lymphoma, which is a malignancy of white blood cells that arises from the lymph nodes. Times 10 to the 9th cells per liter. This is in contrast to lymphoma, which is a malignancy of white blood cells that arises from the lymph nodes. Leukemia can be classified based on cellular lineage. So it's myeloid for granulocytes, which include basophils, eosinophils, neutrophils, and mast cells, and lymphoid for lymphocytes, which include T cells, natural killer cells. If the maturational process is blocked at an early stage of cell differentiation, so that the cancerous cells are immature blast cells with tiny nuclei and lots of cytoplasm, it's called acute leukemia. If the block happens at a later stage, the cancerous cells are slightly more mature with large nuclei and little cytoplasm, and it's called chronic leukemia. Immature cells tend to be less capable of doing their intended job, so they often cause more problems than slightly more mature cells. Acute leukemia patients tend to have more symptoms like fatigue and bone pain. Chronic leukemia patients are often asymptomatic and go unnoticed until a routine complete blood count, or CBC, is done, which often shows a white blood cell count that might be as high as 100 times 10 to the 9th cells per liter. So overall, there's acute myeloid leukemia, or AML, acute lymphoid leukemia, or ALL, chronic myeloid leukemia, or CML, and chronic lymphoid leukemia, or CLL. If leukemia is suspected based on symptoms like frequent infections, easy bleeding, fatigue, and weight loss, then a workup typically includes a CBC, looking for high white blood cell count. If the majority of the white blood cells are neutrophils, the likely diagnosis is AML or CML. If the majority of cells are lymphocytes, then the likely diagnosis is CLL if chronic and ALL if acute. Additionally, a peripheral blood smear is done to look for the malignant cells and their level of maturity, based on their microscopic features. Leukemia is suspected based on the appearance of lots of immature white blood cells. A bone marrow biopsy and cytogenetic testing can be done to confirm the diagnosis and guide treatment. Let's start with CML, which is more common in the elderly and presents in one of three phases. Patients often move from one phase to another, and with each phase, the malignant hematopoietic cells become more immature and therefore more difficult to treat. Most patients are identified in the chronic phase, which is usually asymptomatic, but can cause fatigue from anemia and abdominal fullness, and early satiety and splenomegaly. Patients can also have frequent infections and bleeding due to white blood cell and platelet dysfunction. And this is not to be confused with neutropenia and thrombocytopenia. In other words, the symptoms result from the presence of lots of abnormal cells incapable of serving their function, rather than the lack of cells. Next is the accelerated phase, in which cellular proliferation accelerates. And third is the blast phase, or crisis, in which cellular proliferation gets to a point where it becomes acute leukemia, which can be AML. In some cases, it can even become ALL, which might be triggered by a gene mutation that affects how an early progenitor cell differentiates into a lymphoid cell. It's important to distinguish CML from a leukemoid reaction. A leukemoid reaction is a normal overreaction of the bone marrow to infections or stressors, and it can cause a white blood cell count of more than 40,000 and a left shift. And we all know people who overreact, and from now on, just call them leukemoid. The main way to differentiate CML from leukemoid is that normal leukemoid cells take up the enzyme leukocyte alkaline phosphatase, or LAP, whereas CML cells don't. If CML seems likely, it's important to do a bone marrow biopsy, which will show an increase in the ratio of myeloid to erythroid cells, which is normally somewhere around 3 to 1. But taken alone, this is a non-specific finding, since the ratio can increase in an infection as well. In addition, in a bone marrow biopsy, in the chronic phase, there will be less than 10% blast cells. In the accelerated phase, there will be 10 to 20% blast cells, and in the blast phase, there will be more than 20% blast cells. Finally, we can do karyotype analysis to look for chromosomal translocations. CML is associated with the 922 translocation, which is where there's fusion of the BCR gene on chromosome 22 and the ABL tyrosine kinase gene on chromosome 9. This is called the Philadelphia chromosome. We can look for this fusion gene by doing fluorescence in situ hybridization, or FISH analysis. The presence of the Philadelphia chromosome is absolutely necessary for the diagnosis of CML. The Philadelphia chromosome is also a target of tyrosine kinase inhibitors, or TKIs, like imatinib and nilotinib. But CML can develop resistance to these medications, and a person can go into blastocrisis, which can require allogeneic hematopoietic stem cell transplantation. Alright, on to CLL, which is the most common leukemia in adults and is also a disease of the elderly. CLL is considered synonymous to its lymphoma variant, small lymphocytic lymphoma, or SLL. The difference is that SLL starts in a lymph node instead of the bone marrow. Like CML, CLL is usually asymptomatic and often discovered incidentally, but can sometimes cause lymphadenopathy and hepatosplenomegaly. The CBC might reveal anemia or thrombocytopenia, which might be due to two possible causes. One possibility is that the CLL cells are infiltrating the bone marrow. Another possibility is that the CLL cells are making autoantibodies against red blood cells, called autoimmune hemolytic anemia, or AIHA, or against platelets called idiopathic thrombocytopenic purpura, or ITP. AIHA can be diagnosed by
All right, any questions related to the concept mapping and the care plans? Anything that I need to clarify with you before we move on? Okay, so therefore, next week, Monday, I expect I must be given enough time. I must say a few of you did some really good outline for the
With what?
the ad pie that I asked of you.
Okay.
But it's not just about the contents I was looking at. I was looking also at the presentation and how persons put together and what persons did. And three persons I think really went out of their way to do something, and that is Rika, Sasha, and Sandra. I look at the way they did their presentation, not so much about the contents, but the way that they actually went into the Microsoft, put it together, the things they've learned, and put it in actually in sheet protectors and folders and that. And that's people who are very much organizing themselves. Also with Barbara. Okay, so that's good. But now I need persons also to focus on the contents of what you do. Okay? Now, yesterday we did talk about blood disorders. And the first blood disorder we spoke on was what? No, we didn't talk about the first thing yesterday.
Anemia.
We spoke about anemia. And what did we say about anemia? What was so important for us to understand about anemia? What most people, when they hear about anemia, they think about what? Food. Remember, just finishing the GI. And what did we say at that time? That a lot of the anemias, because you have hundreds of anemias, a lot of the anemias are not caused by food. And remember what's the definition for anemia? It is what?
No hemoglobin.
No blood count is what they normally give to the man in the street when they would pull up to review something. But when you're going to look to understand at the nursing level, we talk with the quantity and or quality of the red blood cells. And we know we talk about quantity, we talk about those microcytic, right? And those macrocytic, and the hemoglobin that's in it that's being affected. And then when we talk about the quality, it's like the sickle cell. You also focus on things like aplastic anemia, hemorrhagic anemia, hemolytic anemia,
Thalassemia.
right, but we were looking specifically at the ones that have, and thalassemia is also. But why we don't focus a lot on thalassemia?
It's not one of the most common.
Because it's not common. When it's a list common drug disorders, thalassemia don't usually come up. But you know thalassemia is usually a hereditary disease, just like sickle cell anemia. But when sickle cell anemia affects people of African descent, thalassemia is more affect people who are from the Middle East, from places like Egypt and that sort of place. There are a lot of thalassemias in those places. But like I was telling persons, we came under what? The slave ship. In thalassemia, sickle cell anemia is on the west coast of Africa. Most of us came from there. Our foreparents. So that's how we got a lot in this part of the world. Okay. Then we went on to something else. We transitioned into the pediatrics. And what was the first pediatric we looked at? Right? And as I'm the one getting old? I was getting old, the second and last. But what is it that we looked at? First pediatric. What? The jaundice, there we go. We talk about the yellow babies. Let me tell you who said so long. You saying it because you're not sure, so you're muffling it up in here. Whoa. I can't hear you. If you got talking to that, it's going into that. All I got to do is, hey, I got it. That's no problem. Mr. Sean, he usually put up his hands. So if you got a problem, just put up your hands and I will see. I won't ignore you. All right? So what did we say about this jaundice and this yellow baby thing? How did the baby get yellow? First we look at why jaundice happens. And we said jaundice happened because of... Now let's not talk about the mother now. Let's talk about the mother. We're talking about just jaundice. What did we talk about that specifically saying why people look yellow? Not just the mother, we're not talking about the mother now. Just talking about jaundice. And then we go back to that. So why was it? Was it?
Bilirubin?
The bilirubin. Bilirubinemia, right? But what is it that gives you the what? What's broken down?
The red blood cell.
Erythrocytes are broken down. And what is in the erythrocytes? The hemoglobin. And what is hemoglobin is made up of? Hemoglobin is in red blood cell. How hemoglobin make up of red blood?
Iron.
Iron is a main component. Right? That is why when you have anemia, they usually give you what? Iron. So you're breaking down these red blood cells like that. Increased breakdown. It causes an increase of what in the blood? Bilirubin. And that is responsible for the yellow, the eyes and the skin. So anything that's going to cause massive breakdown of those red blood cells is going to cause that. You guys with me?
Jaundice.
That's why we talk about jaundice. We say that jaundice is not a disease, it is a what? A sign of a disease.
Yes.
It is not a disease. So you must know the underlying cause for jaundice. So we spoke about a couple of those underlying causes yesterday. And we started with the baby and the mother, right? And the mother, we says RH, negative. Negative. And the baby is what? RH, positive. But what did we say happened? The first baby is okay.
No, but the second one have to get the vaccine, that I know.
But
To prepare the next for the next.
because the first one caused antibodies to develop in the mother. So now when the second baby come around, the antibodies from the mother, it don't pass on through the fallopian tube to the second child. And when the second child get it, they have this what? The antibodies start attacking what? The red blood cells start attacking it. And because it's attacking it, it's breaking those red blood cells down, and that is what responsible for the baby getting what? Guys, look at that.
So which
So we said how we.
so we categorize this one under what type of anemia is this one? Or is just under anemia? Just a,
No, it said
a
under
general state, or just a general topic anemia, or is it a
No,
kind
no,
of
no, no,
anemia?
no. We look at blood disorder. Blood is not anemia. We're looking at babies who are born to mothers who are RH or negative, and babies are positive. It has nothing to do. Don't think about anemia.
No.
Become general disorders now. All right. All right. So what the norm will give the mother? You said it just now. Don't worry, I'm gonna call it. Fast reflexes. So we give the mother what? Some of you had it, right? Nobody is RH negative, so you guys are good. So we give Rogan. What's the action of Rogan? This is only your pharmacology company, right? You remember? What's the action of Rogan? How it does it prevent those antibodies from doing the nonsense that they do. RHOGAM. Right? Some people had Rogan. Okay? Because you don't want to have that problem. And when we spoke about that, we went to something else that happens with mother and child. What did we go to? Come on, let me test. This is your test of your memory of what we did.
We talk about the COVID, how
What did we go to? After the baby being yellow, we went to something else that causes some problem. What's that? Hemophiliac, the hemophilia patient. And what did we say? Again, mother involved, right?
Yeah.
Mother passing on to their male offspring. It has to do with the genes. That X gene that goes down is very imperfect, so it causes a problem in the men. The men have what? XY. And women have what? XX. So she said, no, X. That is imperfect. So it goes to the male, and now he got it to a Y, right? So you have an imperfect X with a Y. So he's going to end up with a problem. But you see, a female have what? XX. That's why you don't see it as much as in females. You guys with me? Okay. This one?
Yes, it said the woman's XX and the male is XY.
XY. That's this one. The genetic breakup of men and women. Alright? So, the baby boy Well, guess what? A blood disorder known as hemophilia. And what is hemophilia? Blood don't clot. Simple. Blood don't clot. That's a blood clot. I'm sure you somebody said blood clot, boy. You guys need to stop. All right, the blood don't, you got the don't go in between, right? The blood don't clot. What? Right, I know I said the blood don't clot. Because them Jamaicans in class, they do some coarse words. That's a don't in between the clot and the blood. Right? So basically that anyway, the blood don't clot. And that caused a problem because you know, if you get an injury, the body's natural defense, it what? It forms clot to stop bleeding. So if the body cannot stop or cannot make clots, any little injury that boy gets, he's going to bleed. And based on that, we said you got to think about what is the nursing considerations for a child who is a hemophiliac. What
Safety measures.
You gotta do what?
Safety measures.
Safety measures, exactly. But when you put safety measures, remember this year we said we gotta be very specific. What safety measures are you talking
You
about?
want to put pads on the edges of the crib so it doesn't harm himself.
Put pads on the edge of the crib, or put pads on the sides of the crib to
Side,
ensure that
yeah.
he's not hurting himself. What's that? No contact sports. So they can't play football and that sort of stuff. What else? Use soft bristle toothbrush. Because when you brush you can. How about a man with beard like use electric instead of air? Right? And that's what you have to put in your care plan if you're going to do hemophilia. So let's think about it. You developing a care plan for hemophiliacs. Nursing diagnosis. What would be the nursing diagnosis for this patient?
Risk for self-harm.
Risk for
Risk for injury.
risk for self-inflicted injuries.
Yeah.
If he's brushing his teeth, he's doing it to himself, right?
Yeah.
But you not patient teaching. But then you ask some patient teaching, how long or what is the life expectancy of a patient with hemophilia?
40 years? 40
What
years?
is the life expectancy
I think
of a
it's
patient with hemophilia?
I think it's 40 years.
40 who? Look, guys, look. So let's guess right now. You got it right in front of you, look it up, please.
10 years. 10 years.
I think they live longer now, that's why I said that. I think they live longer now, that's why I said that.
10 years less than what? About 10 years in a healthy person. Less than 10 years. So if a person is not healthy,
Wow.
they're going to die earlier. If a 10 years is in a healthy person, if the person is not healthy, they're going to kick him off it earlier. Is that so? So,
But they say some people live longer.
some people can live longer.
Only 20 years.
But remember, what is the normal? What's the normal for people to live? Life expectancy has been going up every year, right? People have been going up to 80, 90, but now the average is around something like 80 or something like that, right? to do it into that nice old age. Earlier in the century, in previous century, when people reach in their 30s, they're considered to be old. I kid you not. When you go back in the centuries, when you used to use what? Swords and them sort of stuff. When a person reaches 30, they're considered to be an old person. Now, in this modern age, we've put on what? About 50 years on that. When a person, just to see how we talk these days, when you say a person died, a man was only 50 years old. Please be shocked, right? Because they said 50, that's a young person. Back in the days, he's an old man. So that's the difference in life expectancy. Okay? And of course, we know that women live longer than men. And why do women live longer than men?
Because they give us the headache. Because they
Why
don't,
do women live longer than men?
they don't have to deal with the headache.
No, it's not that. Like, you know, you must be something about that.
They give us the headache, yes.
You know they're saying, and stating, and if you want to go this or not, they say that what? Stress kills.
Kills, exactly.
So therefore, men are stressed out.
Preach, Pastor.
So women
Preach.
I'm done, let me stay there. And that is, by the way, God goes with that, guys. I just
Just stress men
Alright.
give women.
You ever hear a woman dying from stress? I don't think I ever hear a woman die from stress.
Many
That
times.
people do resistance.
All the time.
Die from stress.
I used to work in a nursing home and then give a woman a stroke because he saw her him in bed with another woman.
Yes,
And then she was young, she got
a
stroke.
young woman.
The
I
man
know
come
that.
see her because we didn't know. Every time he saw the husband, she started crying.
Yes,
but the man
until-
walked in with that
A beautiful
sibling and the
Spanish
family blocked him.
beautiful.
They don't let him come to the nursing home.
I said, you a fool. You let them and destroy your life.
Most common
You know,
important
we said that recently that pretty young Miss America jumped off the thing and died, right? She's only 30. So she died from what? She was depressed. And so she becomes suicidal and she jumped out. She's depressed. But guess what? She had a lot of money. She was a lawyer. She was working for a TV station. And she was a Miss America. So she had brains and beauty.
And smart.
And still jump over and kill herself.
A man, that's a man. That's a man issue.
But you know
That's
what?
where men come
She
from.
must have got more men genes in her or something. Because usually a woman, when she have problems, she call everybody.
Not true.
And she don't want to kill herself. Before
That's
she
true.
kills herself,
I'm not gonna
she calls
kill
the mother, she
I will tell
everybody for tell them, you know what? I don't want to live anymore. I'm going to drink something. And everybody run to the house. When they go there, they find that she drinks some vitamin pills.
They don't worry.
And I don't tell. My son and man got a problem? You don't jump over the water.
You just walk in front of my
You see
car.
a train coming up,
Exactly.
That is why, if you're here recently, and I think the men are trying to get back because recently you heard a lot of people being pushed under the trains, right? And most of the people are pushed are women. As men,
That's a bad joke.
Men pushing the women. So what do you want to
bad
think? That maybe the stress are getting to the men and they're what?
Well, go find a woman that's just right.
Stress is getting to the men so they cannot what? Handle the situation so they do what they gotta do. That's it. Tell us what?
Quantitative efficiency factor. Factor 8.
Tell us ex-wife and his girlfriend.
V111. That's 8.
Yes. Oh, yeah. B is 5.
Oh, yeah,
For counting, one bar is 6, the second one is 7, the second one is 8, the third one is 8.
And where is from here?
Easy. V is 5,
Okay.
All right.
6, 7,
I
8.
got
Right,
it.
Papa?
Thank you.
When we come to do our
show me a lot.
psychiatric
Thank you.
trials, we're going to talk about all of these. So let's go back to our
We don't want to know.
blood disorders. So, come on guys, come on, let's go back to blood disorders. What she's looking at? She's looking at me? No man, she won't look at me. Something wrong with you. If you look at me, or any woman look at me, something is really wrong with that woman because they need eyeglasses. English. I am an ugly man.
No, you're not ugly.
Secondly,
Just for people to
I don't like women.
Then you don't like flower.
I don't like women.
You don't like flower.
That's a lie.
I am a hermit.
That's a lie.
So you ain't gonna find my eyes on any woman. I ain't gonna see my eyes on no man.
Lie from
I am a hermit. All I have eyes for is myself when I look in the mirror. Nobody else.
It's a lie straight from hell.
Is the light straight on it?
Yes.
Hell.
You ever see me watching a woman in here?
Huh?
You never see that thing. You never see me doing that.
Oh, why you say Barbara?
Especially when Barbara's dance. Alright, let's move on. So the last thing we talked about was the hemophilia.
Hemophilia.
We talked about the nursing considerations. Then we went next to what?
The cause. The cause.
The safety measure.
We went to how you identify the bleeding because of these guys is bleed, right?
Yeah.
And we went to 3 types of bleeding. And the 3 types were porphyria, okay, ecchymosis, and petechiae. And all is bleeding under the skin, right? But the thing is, you got to look at it, what is the underlying cause, right? And you know, yesterday we look at what? The images. So you can get a better understanding of what it looks like. So when you see it, instead of just writing on the paper, this patient has porphyria, you don't even know what porphyric spots look like. Or this patient had ecchymosis, you don't know what it looks like. That's a concern. You must look and see and able to identify. But always remember, when you are writing notes as a nurse, unless the medical diagnosis has been put in, you put patient have a discoloration to the skin. If this guy had a big black and blue area down here, patient have a, why don't you measure it? 10 by 15 discoloration. You can even say blue black discoloration. You can say red discoloration. But you can put discoloration. Because just like we said, porphyria, ecchymosis, and what, you don't know what it is. So why would you go put in ecchymosis? And we know ecchymosis could be due to trauma. But the patient might not have trauma. The patient might be a hemophiliac and sleep on something that was in his bed that was hard. So when you get up, you have what? So just please put
Discoloration.
Right? Put discoloration. When you have cancer in the blood now, That's a whole different story, right? And that's where we're going to get into what? Leukemia. And we have the different types of leukemia, right? So which is the most prevalent leukemia?
ALL?
AML. Somebody read AML, please. Anybody?
There's a type of cancer in which the bone marrow makes a large number of abnormal blood cells. Leukemia may have red blood cells, white blood cells, and
Platelets.
platelets. Sorry.
And what is the next one? So, go read, somebody read CLL, please. Gotta be much louder.
Speak from your chest.
You gotta bring it down like that so you can speak. Alright? So let's go, please.
Chronic lymphocytic is the most common leukemia in adults. It's a type of cancer that starts in cells that become sharing with white blood cells called lymphocytes in the bone marrow. The cancer leukemia cells starts in the bone marrow but then go into the blood.
Next. What's the next one?
CML?
The one she just read is CLL.
CM.
What is CML now? CML.
Chronic myeloid leukemia.
That's not have AML. We have CML, right? CML. So let's have CML. Somebody read please.
Neoplastic monoclonal proliferation of mature granulocyte precursors. Mature granulocytes accumulate in the bone marrow. Physical suppression prevents maturation. It is associated with the Philadelphia chromosome.
So what you hear in the acute and the chronic, you hear there's a problem with the bone marrow that's responsible for producing blood vessels. And the one that is most common of the three is your
Acute CML.
Read back CLL, please.
CLL. It is neoplastic monoclonal CLL, chronic lymphoid leukemia. It's a neoplastic monoclonal proliferation of mature, functional, abnormal B lymphocytes in the bone marrow, blood. Mature B lymphocytes accumulate in the bone marrow, causing physical suppression, and it prevents maturation.
Which is the most common? Which is the one that people get more often than others?
Most
See what? Somebody just said CML. I heard CML just now. All right, guys. Listen. Please put. What is the most common type of leukemia? Just put it in, please.
What is the most
Just what is the most common type of leukemia? What is the common most
What is the
common-
most common type of leukemia?
Read it, please.
ALL.
But they do said CLL and AML are more. So they said
Okay.
CLL is the most common leukemia
Eh?
in adults. In adults.
They said also called
Myeloid is in adult. The CLL is in
They call
adult.
it acute
As a common leukemia in adults, the children can this cancer. AML starting bone marrow and quickly spread into the nodes, organs, and chemotherapy is the top
CLL or
In both children and adults.
All right, listen to me very carefully. Please. The next question I'm going to ask you, because it must be a division. What children get, what adults get. What is the most common leukemia affecting children?
ALL. ALL for children.
Please read it. Guys, stop. What ALL stands for?
Acute lymphocytic leukemia.
No, come again.
Acute lymphoid leukemia.
ALL.
Acute lymphoid leukemia.
Lymphocytic. Lymphocytic.
lymphocytic.
How much is the English, Mr. West?
Is the most common form of leukemia in adults. Back on them now.
All right. Still.
One of them.
You have ALL, right? And what is the manifestation of ALL? What is the first thing when you say manifestation of ALL? We said children. What age does it start? What is the most prevalent
15 to 20. 15 to 20 years old.
Young children, yeah.
No. You hear what you just said? You hear what you say? What did you say? Or what did you say?
I read 15 to 20 years old.
No, stop. Read what you just said.
Young age, most common leukemia in children. B, all peak incidence in 3 years old. T, all peak incidence at 15 to 20
I'm
years
not asking you
old.
to question. I'm asking you to look for what caused it. Not the question. Don't be questions.
No question. Okay.
No questions.
Okay. This
They have to
right.
speak a little more loudly. Okay, good.
This is at 3. So 3 to 20.
So the mean age will start from 0 and not really end at 15. It will go as far up to 20. But usually between the ages of 0 to 15. Now look at onset in adults. And remember when you did your growth and development? You have what is adolescence? And what is adults? What age? You got to keep remembering these things. Don't just do it in growth and development and forget about it. You have the neonates. You have the infants.
AML.
School age, adolescents, you know, took the adults, right? You had specific things up to people within specific growth range. Now, which is the most common in adults?
AML.
What is the age group for AML? Read what you have. Now from the paper, I want to read straight from the site.
AML is generally a disease of older people and is uncommon before the age of 45. The average age of people when they are first diagnosed with AML is about 16. But AML can occur in children as well.
What age was that? I didn't hear you.
He said about 68, but many of those so 65 and older.
Okay.
So they
Before the age of 45.
Yes.
You know.
yes, one says 65 and up. It's not before the age of.
This is where navigating your laptops come in. Do not look for what information they give to the person or the person in the school. Look for the information that they give to who? Nurses. Not for the information they give to the person in the school. They just give them an idea. If you go to Sloan Kettering, Memorial Sloan Kettering site. Red Hill, Kansas, right? Call it. Go to their site. Until they break it down very and you break it down into what is leukemia. It's a .org site. What causes leukemia? And what are the types of leukemia? And then under that, it gives you acute lymphocytic leukemia, ALL. It gives you acute myeloid leukemia, AML. It gives you chronic lymphocytic leukemia, which is a CLL. It gives you chronic myeloid leukemia, which is CML. It gives you myeloproliferative neoplasm and systemic mastocytosis. So it gives you 6.
Memorial Sloan Kettering. Memorial Sloan Kettering.
If you put in what are types of leukemia, they're going to give you different sites.
Okay.
Just choose Memorial Sloan Kettering /.org. And that's it.
Professor.
And you can use this to just read. Okay?
What is calling it?
So let me, because I've asked you guys to read so we can discuss today. So let's read together. Maybe this might be more helpful because... Alright, leukemia is a group of cancers that originate in leukocytes, which is your white blood cells. These are the white blood cells that form in the spongy inner part of bones called your bone marrow. Other blood cancers that are caused by defects in the bone marrow include the myeloproliferative neoplasm and systemic mastocytosis. Those are the other 2 parts of the 4 that we just talked about, the AML, CML, CLL, and all that nice stuff. Now what causes leukemia? Most white blood cells live for just a few hours or days. It's unlike your red blood cells which go for 120 days. Some of them just live for a few hours. They are continuously replaced by new cells when they die. Leukemia develops when the genetic material, which is your DNA, in the white blood cells is damaged or altered. These cells don't mature or become fully functional. As these immature cells multiply, they overwhelm the bone marrow. This stops or slows down the production of normal white and red blood cells, also the platelets. You guys understand that? Let me go one more time. Listen please carefully. It's saying that the white blood cells usually live for a short period of time. And they are continuously being replaced. But sometimes the genetic material, which is the DNA, is damaged. And when this damage happens, it creates a problem. It causes the bone marrow to start to multiply cells that are non-functional. Be it red blood cells, be it white blood cells, or be it platelets. That is, be it their what? The erythrocytes, the leukocytes. Remember where it originated? In the
Bone marrow.
leukocytes. The leukocytes cause damage to the bone marrow that is producing all the cells. Because the bone marrow produces all the blood cells, right? But when you have the DNA that's being damaged and alter the function, then it will now cause damage to your bone marrow. And when you get this damage to the bone marrow, it causes problems with the production of
Normal.
your white red blood cells, your white blood cells, and your platelets. Are we with that?
Yes.
So that's how leukemia will start. All right. So now what are the types of leukemia? It says doctors has categorized the types of leukemia in a few ways. One way is based on which kind of white blood cell is involved. Either the lymphocytes or the myeloid cells. Another way is by determining whether the illness is developing very quickly, which is called acute disease, or slowly over time, which is called chronic disease. All the blood cancers may involve the overproduction of different types of blood cells. Now, the symptoms vary depending on which type of leukemia you have. And the first one they look at as the acute lymphocytic leukemia, which is ALL. Now you click on ALL, it's going to take you to another site, to another page, and you look to the far left, and you click on acute lymphocytic leukemia, or all, and it says here that acute lymphocytic leukemia is a rare cancer. It affects about 3,000 adults in the United States each year. The incidence of the disease increases with age. It is less common among women and African Americans. In children, however, ALL is the most common form of leukemia. It accounts for about 3/4 of pediatric leukemia cases. If you are a young adult who has been diagnosed with ALL, you may receive the same treatment that are used for children with ALL. And this is where we were talking just now about the growth and development scale that I was talking about, right? It might be happening at the adolescent stage, but it's usually will be happening in your preschool. Now, doctors may perform tests to diagnose ALL. Tests allow us to understand specific things about the cells for leukemia you have. We look for genetic changes, particularly rearrangements in the chromosomes. These chromosomes are tightly coiled strands of DNA. They contain all the information that cells need to function normally and reproduce. Rearrangement in chromosomes are common in ALL. Other tests look for specific proteins called antigens. And you know you've seen antigens before, right? And when did we talk about antigens? when we did our what? Our overview of microbiology.
Immune system.
We talk about antigens, the toxins that affect. Guys, look up antigen. Look up antigen, please. We went through antigens before.
Antigen. Antigen.
What is an antigen? Somebody just give me an antigen. Somebody read it. Anybody. When you are given a dead or attenuated microorganism, that's an antigen. It helps your body now to develop what?
Antibody.
To fight against
it.
If that comes again, like the vaccine. We talk about some of those guys, it happens every single month. Keep these things with you. Alright? So when you're now reading about this leukemia, you'll fully understand what you're reading. Alright, let's move on. I will come out of, and let's go to AML. And acute myeloid leukemia. And the doctors usually do a variety of tests to diagnose AML. These tests allow them to analyze the specific features of the leukemia cells and look for any genetic abnormalities, such as rearranged chromosomes or gene mutations. Both of these occurrences are common in AML. And the doctors may also look for specific proteins called, in the same word, antigens. And these appear on the surface of the
leukemia cells.
Now let's say each person with AML has their own treatment needs. Standard recommendations include what?
Chemotherapy
and blood or marrow stem cell transplants. Many people with a form of AML called acute promyelocytic leukemia are first treated with arsenic trioxide, trisonox, in combination with all trans-retinoic acid, which is AFTRA, also called tretinoin, which is vesinoid, and development of both AFTRA and arsenic trioxide was pioneered, but they went on to talk with themselves, which is the hospital. So chemotherapy and transplants are used commonly for treating. Now let's go to which one the two you said was kind of rare? Of the two that I read, which one's the rare one?
The first one.
ALL.
ALL.
Now listen to this one. Acute, which is APL. Acute promyelocytic leukemia is an aggressive type of acute myeloid leukemia, which is AML. It happens when there are too many of the blood-forming cells called promyelocytes in the blood and bone marrow. A buildup of the promyelocytes leads to a shortage of other kinds of blood cells, including your red cells, your white cells, and your platelets. The symptoms, which is due to normal red blood cell shortage, they include fever, fatigue, loss of appetite, and frequent infections. People with APL are also at an increased risk of bleeding and forming blood clots. Why are they at risk of bleeding and forming blood clots? Why do you think they're at risk of bleeding and forming blood clots? Come on. Critical thinking.
The platelet formation
Because of platelets.
Cannot be.
Remember once the bone marrow is damaged? If the bone marrow is damaged, then it's not going to be producing what? Platelets. And you need the platelets to form what? Clots. So you will get that problem. Alright? That is why with some of these leukemia treatment, they just don't do, they do chemotherapy like to slow it down. But the real thing they want to do is transplant.
Blood transfusion. Transplant.
Transplant, bone marrow transplant. They want to take bone marrow from somebody who have the same type, the family member, and transplant because the bone marrow is what? Damaged. And that is what's producing these bad blood cells. So they want to replace it. Because when you give chemotherapy, look at what chemotherapy targets specific cells, but it also can damage the good cells. And then look at all the pump together chemotherapy. People hear what? Falling out. There are all kinds of things happen to the skin. Okay? Alright, so let's move on from that and we go to CLL.
CLL.
Which is chronic lymphocytic leukemia. CLL is the most common chronic leukemia in adults. Alright guys? CLL is the most common in adults. About 20,000 people in the United States will develop CLL this year. And this is according to the American Cancer Society. The average age of diagnosis is 72. Old people business. I gotta start watching it, boy. I don't know why old people get all these problems. When COVID came out to old people. Oh my God, I don't know what's going on. I will tell myself that I'm 27. You guys are better than me. They say that the belief kills the belief cures. I gotta believe what I'm saying. Alright. The disease is twice as common in men as in women. So men get it more than women. And usually start in the older age. You know, we got a lot of money, right? Oh my God. So you're putting a hit in leukemia for the poor man. Alright. I'm not going to go how to diagnose and all that. I'm going to go how treatment is recommended for people with CLL varies. Many people who have CLL but don't have symptoms only need to be observed. People with the symptoms may have fatigue, night sweats, or enlarged lymph nodes. Remember, lymphocytes, right? And treatments are designed to bring on remission. Remember, not treatment is done to do what? Cure. And treat to do what?
Reverse.
Remission. Because normally people who have cancer don't have a cure. It is just like HIV. When you got it, you have it. Alright? Unfortunately. No, not really. If you do, just magic cards still have it. They use stuff to bring down the level. They bring down. But he got it. But if you get a cure, trust me, things will change. Condoms will drop. The sale of condoms. Once you have because the man will say, let me just take off the shots.
You don't find the kids because they don't want to, because it's not being here for like centuries.
Well, the 70s when it come wrong in the 70s, when the hippie movement was around, people were having free love. Then is when they really start talking with AIDS. And then they start talking with monkeys and all kind of stuff. You know, it's just like how they talk about this COVID-19.
But they say they found a cure and then...
Don't listen to these things. In fact, I was looking into some stuff today on the use of mass media. And it's getting worse now because even the common man can go on Facebook and what have you and put information that is crap and people look at it and follow it, unfortunately. And it's also being used by different factions to propagate nonsense. Like the problem we had at the White House recently, right? In healthcare, it also has created some issues because of privacy of information. Although you have HIPAA, you find a lot of information is being lost because anybody who knows computerized system can get into anything they want. And just think about it. We are moving towards what? Money, right? And right now we talk about what? Bitcoins? You know what I just learned today about the Bitcoins? Others have been dropping, right? You know it's been dropping. But guess what I learned today about Bitcoins? You know that country that shoots off a rocket all the time to North Korea? North Korea, because they have all of these bans against them, exporting things and what have you because of their aggressive nature. They have been what? Their hackers are hacking into Bitcoin to millions, multi-millions. So they are sustaining their economy through something that just came out, which is what? The Bitcoin, started in Philadelphia. The North Koreans are using it for their economy. And people like me and you who put our money into Bitcoin find it what? Plummeted.
Oh, I took my money out.
It's got some work yet to be done, okay? But some people got very rich with it. I know one young lady who have got extremely rich and bought places in Florida and all kinds of stuff. So you could do things. All right, moving on.
If you're lucky, you're lucky. No, but you have to put money on it.
No, but that's if she was lucky enough. And then they have to...
Right. Some people just are just lucky, man. And they started it.
I should start it. I'm lucky.
No. All right, guys, come back to me, please. Now look at CML. Approximately 5,980 cases, new cases of CML diagnosed in the United States in 2014. It's a long time ago. It was like 5 years ago. The average age at diagnosis is 65, and the disease is slightly more common in men than women all the time. In recent years, increased population of younger people have been diagnosed with CML, but the reason for this is not currently understood. CML develops when genetic materials exchange between chromosomes 9 and 22 to generate what is called the Philadelphia chromosome. Doctors perform various tests to diagnose disease. All right. And I'm not going to go further than that. What I want to know is that the CLL,
The most common.
and usually in get older, you can have the other diseases, right? And the time that you kind of like really, because remember with even with CML, you may have it, but there's no what? Signs and symptoms. And that's how what COVID-19 will take you out, right? Because you don't have any signs and symptoms, but you have leukemia. Just do remember that it is a cancer of the blood. Right? And this cancer is because white blood cells have been damaged, and they now have caused problems with your what? The bone marrow. And now because of those white blood cells, the bone marrow now has been affected in the production of what? All of the cells, whether the erythrocytes or the thrombocytes. And that basically is what your leukemia is about. Understanding that when a person has leukemia and it has been diagnosed and the person is actively suffering from it, that the option is usually what? Chemotherapy. But the best going is the transplant up there because of the bone marrow that is damaged and producing all the bad stuff. But people can be sitting waiting for transplant and it don't happen because they don't have what? A match.
Or money.
Or money? That too, yes, you're absolutely right. Money, please keep this site to, because when we come to do oncology, oncological disorders, we're going to use Sloan Kettering because they deal only with cancers, right? And when you want information on any type of disease, go to a society for that disease. If they have a sickle cell disease society, you go to that society because they have the most what? Recent information. They have information that's more recent than the textbooks. What's happening now? So, whenever you go to a site and looking for information, try to go to those sites that are associated with societies. Society for the blind, they could tell you a whole lot of stuff about blind people. Society for the deaf, they could tell you a whole lot of stuff about deaf people, right? Same thing goes with leukemia, same thing goes with everything. Even the people who drink a lot. Alcoholic who?
Anonymous.
They'll give you a lot of information. It may sound like a joke, it's not, it's very serious. They'll give you a whole lot of information. Alright? Okay. Guys, I really want you to understand how to use these laptops when researching. Okay? It's very important for you to be able to navigate. Because if you listen when I ask the question, some people say X, some people say Y for the same question. Because of the different sites that you're going to. That is one of the main things that you need. Try to focus just on the sites that is for nurses, not sites that are for the common man or here who want to do something with himself. Okay? Why is as soon as 8 o'clock people start shifting and moving and start to like don't text separately. You text separately. I didn't call nobody name. You see? Guilty people. All right. So we kind of look at. We did another Luco something yesterday. What was that? We did Luco something else. I didn't say no leukocytes. Leukocytosis. And what is leukocytosis?
Wake up.
Everybody looking around with, what's leukocytosis?
Leukocytosis.
Even the person who mentioned it, what's leukocytosis? Oh Lord, have mercy. I think you guys just look at me just because I'm ugly. I don't remember anything I say. An increase in the white blood cells. When you have lots of white blood cells. Leukocytosis. I want you guys to remember something you just heard. Leukocytes can die in a couple of hours. Because what leukocytes do? They fight. And when they fight, they die. And when they die, how do you know they're dying?
Pause.
By their purulent discharge, pus. And when you see that white discharge, it's your white blood cells.
Count.
That's what it is. But when you look at the lab test, what will you be looking for? To know if you got infection. What blood test you looking for?
Leukocytes.
Blood cells you looking for.
The what?
The white blood cells, because the white blood
All right, you're going to see an elevation in
White blood cell
your
count.
white blood
WBCs.
cells.
And when you see an elevation in your WBCs, it not mean that there's an
Infection.
infection there. But when identify infection, what else you have to identify? When the doctors see, oh my God, this patient got a problem in the blood, they shot in the blood, got elevated WBC. What do you think is his next step? Because you sometimes will be telling the doctors what they got to do, especially them young ones. So what do you think you got to do next?
Which time?
You do a CBC and you come up with this excessive now. What needs to be done next?
You go to the blood to see which kind of infection.
Look for, she said, look for the site. What is causing the infection? And then when you found what is causing the infection, for instance, the patient might be having a UTI. And how we know that a UTI? The patient can be complaining of what? Dysuria. But patient might be having a catheter in. And once you have a catheter in, we're not going to complain of dysuria. But because you have a catheter in, it puts the patient at risk for urinary tract infection. Because a catheter is what?
Not
Invasive. And right away you say, hey, let's can do a culture sensitivity and come up with what is the causative microorganism so you can effectively treat it. And that's where your antibiotic what? Stewardship come in, because before doctors used to do things based on what they suspect. It's not what suspect anymore. They have to come up with a diagnosis that is based on scientific results. What are their lab results? What is the chest x-rays? They can't just say, oh, you know, you went to go to the doctor before, and you say, I'm putting you on a broad spectrum antibiotic. They love to do that. I'm going to put you on ampicillin.
They still do
And they
that.
don't know what it is about.
They still do
If
that.
you go to your doctor and he does that, you need to ask him why. And by the way, that's what people are being trained, are being taught. Not just the nurses. Because in every facility you know you have your what? What's the person who is in control of that? With antibiotic or what have you. Who's the person that controls the use of antibiotic and infections inside the building? Healthcare building.
Infection control.
No. Was it? Infection control. The infection
There's a
control is
title.
called
The title for it.
infection preventionist. She is a nurse, or he's a nurse. And the doctors gotta listen to her or him. When they go for do something, and she sees, she said, look, she look at her line this and said, what are you doing? And they gotta listen to her. Everybody gotta listen to that person. The doctors, the nurses, everybody gotta listen to the infection control preventionist. And it's a nurse like yourself who's been trained in infection control. Just a nurse like any one of you. But that shows you the authority and the power, if I use that word, that you nurses have.
Only nurses.
Once you have the knowledge,
And
people gotta listen to you. including doctors. Alright guys, you have some time between today and Monday. You have today on, I'm not talking about tomorrow yet. I talk about today, you have between today, it's your time, you can do whatever you want. You can call it today, but I'm saying you have from today until Monday to do their what? The concept mapping before the care plan, so what's in the concept map will go on to your care plan. The same, I said the same, I don't want to give you extra stuff, I don't want you guys come and tell me that it's too much, which you should do, really should do another one, but I want you to say what you have. The same scenario, this one said, the same thing that you did before, you have it already.
I don't have the
Just work on it, you have it in your system, work on the concept map, and then go to your care plan. Because your concept map is what you will be developing your care plan with. Are you guys with me? You can't sing, so stop singing. Concept map, concept map, concept map, then care planning. And this will be a continuous process with care planning because you have to understand the disease process. You see the pathophysiology part? If you don't know the disease and you don't know the manifestations and what you do, including lab tests and pharmacology, too bad for you. That's all I can say. You will have to study and put yourself into it. No more, I think, maybe. No more of that. It's not going to happen. If you don't want to listen to me, and you want to look at them kid, definitely. I know what's allowed. I know how to work.